Hello, and welcome to the next segment of the UVA Mini Med School Special COVID-19 Charlottesville podcast, titled Severe COVID-19 Management in the ICU. My name is Tomek Dobrzanski, and I'm a third-year medical student here at the University of Virginia. Charlottesville hasn't yet seen the case burden that a city like New York City or even Washington, D.C. has. That does not mean that UVA is not feeling the profound effects of the disease inside its hospital doors. On the news, we've been given brief looks inside hospitals, as well as speculation about treatments. But today we have the pleasure of speaking with a few healthcare professionals who have experienced the worst of COVID-19 in our ICU and who can provide insight into how the disease can unravel and what is being done for the patients who are affected most. I'm excited to be here with Dr. Alexandra Kadl, a pulmonary and critical care specialist who cares for our sickest patients found in the intensive care unit. Thank you for joining us today, Dr. Kadl.
Thank you for having me.
Medicine is a team effort, and we'd be remiss not to elicit the perspective of our nurses who play an integral role in caring for these patients and truly are our boots on the front lines of this pandemic. I'm happy to welcome Mike Little, a nurse practitioner, and Sam Chase, a registered nurse, who have been gracious enough to join us in lieu of a nap or valuable family time. Thank you for taking the time, Mike and Sam.
Thank you.
We'll start with Dr. Kadl. The intensive care unit focuses on treating the sickest COVID patients. Why would a patient need ICU care, and what complications are we seeing in these patients?
That's a very loaded question. And so patients that develop COVID-19 disease often have respiratory problems. So they breathe very heavily and their oxygen levels drop very low. And the things that we can provide in the intensive care unit is way higher amounts of oxygen than you would usually get with just a nasocannula tube. We can provide what we call high flow oxygen, and then of course mechanical ventilation, so basically a breathing machine on which the patients are put on. And what we've seen is that those patients, they don't behave like we often hear it's similar to flu, but they actually don't behave like that. They are sicker for way, way longer, and they are very, very hypoxic, profoundly hypoxic, and they need a specialized team that can handle that. And so what we often do is they are often intubated and on mechanical ventilation on the maximum amount of oxygen that we can provide, and they still are in trouble. And so in the ICU, we can offer other therapies such as what we call proning. So we put them on their belly, which really improves the oxygenation. And then there are also some machines that we can add, like a machine that actually oxygenates blood from the outside. And so we've seen that in our population too.
Thank you, Dr. Kadl. Over to Mike. Certainly during the pandemic, there has been concern nationally over having enough ventilators. Could you talk to us about who needs mechanical ventilation over less intrusive forms of oxygen therapy? And has UVA had any difficulty meeting the demand for ventilators?
So I think the quick answer to the second part of that question would be that no, we haven't had any trouble as of yet meeting the need for mechanical ventilators here at UVA. The medical center at last check has about 150 ventilators on site, and we haven't had to tap into a substantial portion of that reserve yet. In terms of who needs mechanical ventilation, that's a little bit more sort of ambiguous, but there are some general rules that we typically follow in any patient population. One would be so loss of the patency or the openness essentially of the airway. The second would be the patient's ability to protect their own airway from things like secretions. Say they had a depressed mental status perhaps and couldn't effectively clear their secretions appropriately, they would be at risk to aspirate those into the lungs, causing a pneumonia. Another would be an inability to effectively expand and sort of retract the chest wall to blow off carbon dioxide. Derangements in circulatory flow that would make it difficult for them to take in the oxygen and then deliver that oxygen to the bloodstream so it can be delivered to the organs effectively would be another reason too. And that's kind of what Dr. Kadl was talking about with sort of refractory hypoxemia. And then typically patients that we can anticipate based on sort of a rapid clinical decline that their hospital course will involve mechanical ventilation at some point. Sometimes we will sort of get ahead of things by putting an airway in at the start to avoid a more emergent intubation later that would place the patient potentially at higher risk. I think in the COVID population specifically, we don't necessarily, because of, we need to prioritize sort of disease containment more so with COVID-19 than we do a lot of our other disease processes that we would typically see. So a couple of respiratory therapy modalities that we would typically employ for somebody in some level of respiratory distress, we don't have available in our armamentarium to fight COVID-19. So one of those specifically being CPAP or BiPAP. That's one of the main therapies that we use sort of as a last ditch effort to avoid intubation. That's not really on the table for this patient population because it tends to aerosolize secretions and can increase risk of exposure to the virus for our staff and the public at large. So one of the things that we've done is or one of the phenomenon that have sort of come out of the COVID-19 pandemic for us, and perhaps it's been around for a while, but just lesser used, is this concept of sort of self-proning. So proning, Dr. Kadl also referred to that, but it's a therapy that we actually take the patient and flip them from their back to their stomach to essentially re-recruit areas of the lungs that are sort of lower and more posterior that a lot of times are more collapsed and they're not really participating in oxygen exchange as we would like them to. So for patients that are able to, we can actually get them to roll themselves over from their back to their front without a breathing tube in to recruit those areas of the lungs and hopefully improve oxygenation and avoid intubation in the first place. Other than that, I think respiratory distress, I guess, is kind of the next thing specific to the COVID-19 patient. It's a little bit different because a lot of times these patients will be very hypoxemic, but not necessarily look like it. So they may be breathing fast, but things we're looking for are accessory muscle use. So a lot of times the muscles in the neck, if they're having to use those to breathe more effectively, and also maybe some diaphoresis and that sort of thing, are sort of red flags that we look for in terms of when somebody might be heading toward more invasive forms of mechanical ventilation.
Thank you, Mike. Now over to you, Sam. You are tending to your patients on a minute-by-minute basis and have truly gotten to experience the pandemic firsthand. Could you tell us more about your role in treating these patients and how it feels going from seemingly normal life at home to the front lines of a pandemic every day?
I will say that it definitely feels like we're going into a different world, going to work every day and trying to shut that off when you come home. My husband is actually also an ICU nurse on the COVID unit with me as well, which has its benefits where we can kind of, talk about how the day went, or if we don't want to talk about it, we kind of understand each other on that level. I think the big role that the nurse plays in it is just that we're trying to cluster our care for these patients and, be mindful of the PPE usage. We have been thankful that the hospital has provided us with what we've needed to keep us safe. As far as our goggles and our N95 masks, our gown and our gloves. And so we've really been working with interdisciplinary teams like our pharmacists to try to cluster, medications around 8 o'clock, 12 o'clock, 4 o'clock, and really try to go in there and get all of our interventions done that we need. At the same time, you're also finding that you're in there for, maybe 2 hours at a time or possibly even longer, depending upon the patient's condition and if they happen to be decompensating. And we've all experienced that, the PPE for a long period of time is very uncomfortable. And the things that we thought we could do on a regular basis, for example, compressions, feel a lot different when you're wearing an N95 mask compared to when you're not. And, I think that one of the big things is the emotional part of it. Not having the families be there for these patients. We have kind of become like family, I think. We're doing our best to try to FaceTime people and contact them and get them on the phone and just try to keep them up to date with what's going on and really be mindful that we know that they're feeling the fact that they are not there as well. That sometimes we can make some exceptions, but I think amongst our coworkers, that's really brought a lot of us closer together too. The hospital did a really great job preparing another unit for COVID-19. So we are in the beautiful new South Tower at UVA. And at the same time, we do still have the regular MICU. So it has felt a little separated just geographically. But I think that our team is really doing a great job just going back and forth and being there for, whatever everybody needs. And just trying to be mindful of self-care on our days off. And we all kind of check in on each other. And I think getting outside has been a big thing, just feeling some fresh air and trying not to be, fearful of contracting this ourselves. Like I said, we are very fortunate to have the PPE. I can actually speak firsthand. I was tested for COVID-19 and thankfully negative, but I was on the patient side of that, and I actually had a better perspective of what does the test feel like? What is it like to have somebody walking into my room with all the PPE on? And that really did help me change my mindset too, and how I care for these patients, and knowing that they can't truly visualize what we look like. They just see the personal protective gear. So.
Thank you, Sam. It's important that we don't forget about the mental toll placed on our frontline workers and the need to support you all during this time. Back to Mike. Personal protective equipment, or the lack thereof, has been at the forefront of conversations, and rightfully so. We need to protect our workers on the front lines if we're going to fight this disease. In the ICU, I imagine there's additional consideration for procedures or treatments that potentially aerosolize the virus or put it in the air. What precautions are you and the rest of the healthcare team taking in the ICU specifically to stay safe? And how are families able to see their loved ones in the ICU?
Okay, sure. For the first part of that question, as far as the PPE goes, we've kind of used the CDC guidance as our foundation. I'll just kind of walk you through what our typical PPE looks like. The first thing would be just sort of the prototypical isolation gown that you see a lot of times in hospitals. The next would be just sort of your standard hospital glove. It's a nitrile glove, rubber-ish. We also are wearing eye protection. And for patients that are not intubated and not undergoing some special procedure and are requiring less than 6 liters per minute on their oxygen flow rate, we're using just the standard procedural mask that you see a lot of times kind of in the community. For patients that are intubated or who are undergoing a potentially aerosolizing procedure, at that point we employ the N95 mask for those things. In addition to that, and kind of a step above, I think, here at UVA, is that we've been using dedicated staff who are actually there just to help people both put on and take off the personal protective equipment. So before somebody goes into the room, provider, staff, et cetera, that person will walk them through putting on the PPE, make sure there are no obvious areas that are not covered by the PPE that they put on. And then when they come out, they will actually walk them through a standard sort of checklist to make sure that no steps are missed during that process, because actually during the doffing of PPE is one of the times when providers and staff are most at risk. If you can kind of picture people putting their hands close to their face, you know, with dirty gloves and that sort of thing, that person is there to make sure that none of that happens. As far as families getting in touch with loved ones, obviously I think Sam kind of touched on that, but it's certainly a unique situation, and certainly one in which you can envision that families would feel helpless having a patient or a family member or a loved one who's so sick but not able to reach out and sort of visualize what that looks like. What we've done at UVA is actually partner with our telehealth program. And we have a system set up through iPads and Jabber, which is a sort of an encrypted communications tool that's HIPAA compliant, that utilizes an iPad both inside and outside of the room, as well as a camera device. So inside of the room, folks on the outside can actually visualize the patient, and then there is audio with that, and they can communicate with a provider that's in the room, or hear certain alarms that are going off that'll alert us to different problems potentially that are occurring with the patient. And then two, we've actually utilized that same system to create, much in the same way what we're doing here, sort of a Zoom format meeting with families, where we can have family members in different states who are able to call in, use the Jabber technology and the iPads, and have a meeting to both sort of see their loved one, and if that loved one is able to communicate, actually communicate with them. But if they're intubated, just to kind of, paint a picture of what they're going through, so they can, when they're thinking about, the condition in their mind, they're able to kind of see what actually is going on. So it's been really helpful. I think a lot of this technology that we're using now, hopefully will translate into sort of some more of our everyday practice.
Thank you, Mike. Dr. Kadl, with information emerging daily on the disease itself and new treatments, for example, plasma from recovered patients, hydroxychloroquine, and remdesivir, how do you decide who gets these experimental treatments and which is best? What has been the approach to these by you and your colleagues here at UVA?
So the general approach in our community is that all those therapies, we don't have good proof for any of those to work. And so the general premise was always to use them in a clinical trial. So we really try to avoid giving medicines just based on pure beliefs. We tried to give them to patients when they were actually enrolled into a clinical trial. As you may know, UVA has participated in the remdesivir, the first phase of the remdesivir trial. for which there were some preliminary results already put out that showed that patients that received remdesivir, which is an antiviral drug, had actually a shorter time of symptoms. There was no significant difference in their mortality, but it's a significantly shorter time of symptoms. Now, this trial has actually moved forward into the second stage, where all patients will get remdesivir, and then you are randomized towards a JAK inhibitor, which is an inhibitor of an inflammatory pathway, because severe inflammation is a big component of COVID-19 disease. So that's the second trial on remdesivir that UVA is participating. Now, as you mentioned, there are several other things that have been around and have been postulated as potential therapies. And so the other clinical trials that we are currently enrolling patients for is convalescent plasma. For that purpose, the thought is that patients that had COVID-19 disease created some immunity to it. And if we take their blood and take plasma from those patients, they actually this plasma would benefit patients that are acutely ill. And so we have started to enroll patients for that trial too. It makes kind of sense and has worked in other diseases in the past too. And so we are having this. There's another trial that we are currently enrolling to, where we use mesenchymal stem cells for patients. And so, there's a lot of clinical decision-making at bedside, and we are trying to be a good judge if a patient can be enrolled in a trial. And if they can, we try to move forward with that first.
Thank you so much. Thank you for clarifying how UVA is handling all these treatments that we're hearing about on the news. If I could ask one follow-up question quickly. We've been hearing a lot about blood clots as a complication. Could you tell us which patients are getting these blood clots and what is being done to treat this?
Yeah, so blood clots have become a very big problem in the COVID-19 patients. There have been young patients that have, shown up with strokes, with big PEs, and with big complications from blood clots. And, it is a very inflammatory disease, and inflammation is one part of the clotting triad. You have to have that to be at risk. And so what we do is we measure certain blood parameters, we call them the D-dimer, in those patients. And when they reach a certain threshold, we automatically anticoagulate patients fully to prevent any kind of future clotting, even if we don't have necessarily proof that those patients have blood clots, but they're just as very high risk. And if there's no concern for bleeding, we try to err on the side of being proactive with anticoagulation, so that we don't have strokes, for example, as a complication, because there have been a few case series of very young people who had devastating strokes from this disease.
Thank you, Dr. Kadl. To wrap up, I'd like to extend a big thank you to all three of you for coming on today to share your experience and for teaching us more about the treatment of severe COVID-19. Even more so, we appreciate your hard work and commitment to your patients, both COVID patients and all others. This has been another episode of the UVA Mini Med School Special COVID-19 Charlottesville podcast series. Please stay tuned for more episodes, and thanks for listening.